Welcome, everyone. My name is Michael Fine. I'm a writer and community organizer, a family doctor and a public health guy, and president and board chair of Primary Care for All Americans. Welcome again, and thanks for joining us. We've had engagement from of people from 40 states in the District of Columbia and 322 zip codes so far. People who are working together to build a movement and a healthcare system for the United States that is for people, not for profit, and starts by providing primary care to everyone in every American neighborhood and community. As most of you know and have seen, the crisis in primary care is in the media all the time now. Lots of people can't find primary care doctors. The US is losing life expectancy because not enough of us have a primary care doctor. Probably among adults, 43% or less have a meaningful primary care relationship. And healthcare costs keep going up because not everyone has primary care. So everyone is using the emergency room kind of all the time, often for problems best cared for by their primary care doctor, but cared for in the emergency room in a way that's impersonal and much more expensive. And everyone using the emergency room drives up the cost of healthcare itself. I'm thrilled we're going to hear tonight from my friend, Dr. Wayne Jonas. Dr. Jonas is not only a founding board member of Primary Care for All Americans, he's really a giant in healthcare, someone who deeply understands how healing works at the cellular level, at the level of organs, bones, and joints, at the psychological level, at the spiritual level, at the community level, and even at the national level. Please stay on at the end after Jonas speaks while our board joins Dr. Jonas for questions and discussions. We'll be talking about how you can bring primary care to everyone in your own neighborhood and community. It's now my great pleasure to introduce our moderator for this evening, Patty Armstrong, and to thank the Zoom Committee of Primary Care for All Americans, chaired by Dr. Alan Roth, which organized this room. To thank Dr. Jonas and all the presenters, and to thank John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. Take it away, Patty.
Well, thank you, Dr. Fine. It's great to be with everyone this evening. Thank you all for being here, for being part of PC4AA, Primary Care for All Americans, where together we are building a movement to provide healthcare for all people, healthcare for people, not for profit, in every neighborhood and community. So tonight we are here to both teach and learn from each other. We encourage you to ask questions, put them in the chat. We'll have time to answer them at the end, and as many as possible after we hear from our keynote speaker, Dr. Wayne Jonas. But before that, we have asked John Mormon to tell us about his experience with healthcare. Hi, John. Can you tell us where you're from and share a little bit about your experience with us?
Good evening. I'm John Mormon. I'm from Alexandria, Virginia. And my story involves a patient doctor relationship that's lasted for about 25 years. My primary care physician in my 20s was Dr. Steve Rex in Alexandria, Virginia. And coincidentally, he was in his 20s when I was in my 20s, so we used to call him Doogie Howser. But he's been with me for many years, and in the early years, he treated me for a number of ailments: diverticulitis, sleep apnea, appendicitis. As you can imagine, sleep apnea was 20 to 25 years ago, was relatively new. And he convinced me to use a BiPAP back then. Initially I fought it, but I'm a better person because I started wearing that machine, and my quality of life has been a lot better. And fast forward about 15 years, Dr. Rex moved into a concierge type position with MD VIP, where the quarterly dues were a little bit more expensive, and I always felt that the care that I was receiving from Dr. Rex was well worth it because he knew my story. He also is my brother's doctor. He also is my uncle's doctor and my best friend's doctor. Let's see. I'll always refer my friends to Dr. Rex, and I feel confident in that he'll give them the same care that he's given me through the years. And as my daughter gets older, then he will probably be her physician. And I'm hoping to grow old with him. And it could be a 40 to 50-year relationship. But thanks for letting me share my story.
Patty, back to you.
Thank you, John, for sharing your thoughts and experience. It's these stories that we want to become part of our reality and not a rarity. So we are pleased to introduce our keynote speaker. Dr. Fine, would you welcome Dr. Wayne Jonas?
Sure. Dr. Jonas, hang on. I'm going to have to speak from the cuff because I have, oh, there it is.
You already introduced me, Mike. That's fine. We don't have to have any more. Let's get to the discussion and the presentation, and then we can do that. So,
all right.
Yeah.
Well, let me just say this. So, from 2001 to 2016, Dr. Jonas was the president and chief executive officer of this Samueli Institute, a nonprofit organization supporting the scientific investigation of healing processes in the areas of stress, pain, and resilience. Dr. Jonas was the director of the Office of Alternative Medicine at the National Institutes of Health from 1995 to 1999 and led the World Health Organization's Collaborative Center for Traditional Medicine. He's now president of the Healing Works Foundation. Thank you for joining us, Dr. Jonas.
Thank you very much. I appreciate it. It's great to be here, and it's great to be part of the founding of this organization, Primary Care for All. It is, in fact, exactly what our nation needs. I want to make one correction of what Dr. Fine said about me. I'm not an expert in community. I actually know very little about community organizing, and I joined this because I know he is a complete expert in this, and I wanted to learn, and I am learning, and it's been fascinating to watch, and it's been a privilege, actually, to be part of this. What I'd like to do tonight is take about 10 or 15 minutes and talk about something that we use the word of a lot, and yet we don't really dig down into it around primary care. We assume that we do it, but we don't necessarily do it based on the research and evidence of using the technologies that we have today, and that is the term healing. And I believe that when primary care, especially family medicine, had so much energy many years ago around the biopsychosocial model, which was the term at that time in the 60s for whole person care and the whole person model, the whole person thinking, and looking at the factors that drive healing. We sometimes call them the determinants of health, and then an appendage and adjective to each of that: the social determinants, the behavioral determinants, the mental determinants, the physical determinants of health. But our system doesn't do that. And I believe that if primary care is going to actually generate interest in the country, and if it's going to renew itself in a way that people are going to want it, it's going to have to re-examine this concept of healing. And so I'd like to talk a little bit about how we do that. And I'm going to bring in some information from two other members of the board for Primary Care for All to show how their activities are really beginning to focus on this concept of healing to make it real and measurable in these areas. My work has been largely in systems change, practice for practices and also policy change. I worked a lot in policy and payment. And so rather than talking about community aspects, I'm going to talk about systems change and how does that happen. And I want to introduce these two words that are used frequently, these three words actually, whole person care and healing. And I'm going to introduce another word that many of you may have heard of, but I think ought to be broadly applied and the core aspect of what our new healthcare system needs to look like. And that is the term salutogenesis. And talk about why salutogenesis is really the key to health and healthcare as we move forward. Well, before you treat an ailment, you usually like to diagnose the causes, but here's the ailment that we've got. If you look at our current healthcare system and you ask the question, is it doing well? You can pick almost any parameter and see that it's not. We are first in spending, we are 37th in actual health measures by WHO. Our GNP is gobbling up a growing amount by healthcare. Disparities are increasing. Mental health problems are at a crisis, according to the current Surgeon General. Widespread dissatisfaction, burnout among physicians, including primary care, now over 50%. Decreasing health in children, which means our future is not looking bright. Declining life expectancy. And if you're into global warming, we contribute 5% of the greenhouse gases, and that amount is growing. So I would say that healthcare is not actually creating health by any parameter. Here's one graphic that illustrates it probably more simply than that laundry list that I just gave you. The US spends over double any other country on healthcare per person, and yet our life expectancy is somewhere down Czechoslovakia. Does that exist anymore? Had it exist, or even below Portugal and Korea. The money that we're pouring into healthcare is not producing health, and it's not helping with life expectancy in these areas. Now, when you see the ailment, usually you go and try to find the cause. I was trained as a physician to try to see if I could dig up the cause for the symptoms and illnesses that came into my office. And if I treated the cause of the problem, then the ailment would go away. But if I didn't, then it would keep coming back. And we know the causes of our social ills here because we know where health comes from. We know that the vast majority of health, 80% of it, actually comes from behavior and lifestyle impacts or the social and economic environment in which people operate. Even at a high quality, top level healthcare delivery, and I would make a case for even good primary care, where our current model of healthcare delivery is only producing about, and can only produce about 20% of health in medical treatment. And unfortunately, it's not even doing that well, as I showed you before. We're becoming part of the problem. And so by not addressing the underlying things that enhance our health, we are not getting at the cause, and we're not going to solve the problems that we just talked about, no matter how much healthcare, including primary care, we have. If you look at this graph across the lifespan, and I take care of people across the lifespan from birth to death, we know the factors that enhance well-being and enhance health. And one can actually go along those, and if we focus on, and if people have those aspects, then they have health, productivity, and human flourishing. They also then contribute to the nation and the wealth of the nation. However, if they do not have that, and we do not provide that, they get depleted from birth through old age, and they need increased support and healthcare in those areas. The process at the bottom is called pathogenesis. Unfortunately, I studied only from the book of pathogenesis in medical school, and our medical system studies from the book of pathogenesis, which is how does disease occur? So we know a lot about that bottom line down there. And in fact, when disease occurs, we invest most of our resources in trying to prop it up. What we need to do is pay attention to the top line. The term salutogenesis is the process of healing that our bodies and our persons are constantly engaged in order to prevent disease, in order to recover from disease, in order to maintain well-being, even when we can't. And so I would propose that we need to flip our healthcare focus, including primary care, from a focus on pathogenesis and the disease treatment to salutogenesis and the creation of health. So with that context, let's look at what healthcare leaders and healthcare policy folks are doing. What type of healthcare do we have? The National Academy of Medicine, as you all know, came out with a consensus conference called Implementing High Quality Primary Care. Other reports have come out from those bodies and others, Achieving Whole Health, Valuing America's Health, and there's been multiple publications talking about healthcare, including primary care, and we get a laundry list of these very confusing terms. Primary care, high quality, advanced, first care, longitudinal care, urgent care, comprehensive care, population health care, public health care. And what happens is that we get a scattering of understanding where primary care should focus to solve the needs that I just illustrated that ail us. Here is a graphic that I published trying to pull together all the types of primary care that are embedded in many of these kinds of reports. In the center is standard medical care, diagnosis, treatment, and payment. And this is the way many practices operate. And we now have large bodies coming in and buying up and saying, I can provide this kind of care for you. Amazon, CVS, and others through their clinics that will diagnose, treat, and then collect money. However, that is not considered good quality primary care that's represented in the next rung. I call this the Starfield model of primary care that has been demonstrated to reduce costs and improve health over and over again. It has the characteristics of first contact, being comprehensive, continuous, and coordinated care. Increasingly, those who are frustrated by our system are starting to go out on their own and through direct primary care and other approaches to try to provide this type of thing. And I dare say that I think when we talk about primary care for all, this is the type of primary care we're talking about. And indeed, this would benefit the country. There's no question about it that if we put money into that. But unfortunately, the conditions and the science of today are getting more complex than the Starfield model can accompany. And so we now have additional types of services that have been shown to enhance healthcare delivery and should be integrated into primary care. Mental health, chronic care management, pharmacy services and drug costs, referral and appointment management. Most practices on their own can't do this, and so there are companies that will come in and you can contract with as part of a network to get those kinds of enhanced primary care services. But even then, we're not actually getting to these underlying determinants of health in most cases that I showed in the slide before this. We know, for example, that lifestyle medicine behavior is one of the major contributors, we think probably 60% to the chronic diseases that walk through the offices of the primary care physician and are dealt with later on when the complications occur by specialists. And yet we do not provide very good lifestyle medicine and primary care. And to fill this gap, we actually have a society now, or an academy of lifestyle medicine, that is purporting that. And then the increasing evidence for complementary integrative medicine is rising. And so we have organizations that provide that. Similar things now providing a focus on social determinants of health and population health management. To really do advanced primary care, we would have to do all of these things, which is going to be a challenge. I suggest that we don't boil the ocean. And in fact, if we're going to rescue high quality primary care, we need to have a bit of a different focus. And that is a focus on salutogenesis, healing, and whole person care. So I'd like to suggest we pick out one characteristic here that is overlooked and may in fact provide the solution for the direction that primary care needs to go. And that's the term comprehensive. What do we mean by comprehensive? Well, Bauman and Bazemore wrote an article in the Journal of Primary Care last year, which reviewed all of the literature on comprehensiveness in primary care. And they basically said it's made up of 3 different components, 2 of which fall directly in medical care, disease treatment services. One is the range of services that allow anybody to walk in your office and get 80% of the care, and coordination with specialty services when we're beyond the scope of primary care. But there was a third component that is outside of the medical component that they said was an important part of comprehensive care, and that is whole person care, which they described as the aspects of care beyond the walls of the traditional outpatient visit, including the social, cultural, spiritual, and environmental factors of the patient's health. In other words, those very drivers that I showed you are the underlying causes of our problem, of our ailments here in the nation. And so I suggest that if we want to actually have primary care be a solution to the problem rather than contributing more to the problem itself, we need to pay more attention to whole person care and get at those underlying causes. I think there's 3 things that need to be incorporated into this focus. One is whole person. This doesn't mean everything to every person, but it means that we need to at least address 4 dimensions of an individual to see what their needs are if we're going to customize and personalize the care. First, the body and the external components. Second, the behavior and the lifestyle aspects. Third, the social and emotional dimensions. And fourth, the spiritual and the mental components. And there ought to be an opportunity within primary care to have a deep discussion about those with every single patient at least once a year, if not more often. Second, we need to focus on what matters to the person. The person has to be an integral part of their own health creation and health promotion. To do that, we need to know what matters to them in life, and we need to explore not just the social dimensions, but in some case, whatever comes together for their personal determinants of healing. What do they need to drive salutogenesis? And then third, we need to make a major shift from pathogenesis, disease treatment only, over to salutogenesis, and provide the resources, the training, the focus to drive health, not simply treat disease. How might that look like in a system? Well, the VA has created an approach to this called whole health, and others have written models. This is a model that I was co-author of in the Journal of the American Medical Association Health Forum, recommending that in addition to the pathogenic components that we have in disease, that we build the resources to produce salutogenesis, or whole person care, that you can see on the left-hand side. And that this is what the new model of healthcare to address the healthcare nation goals needs to look like. Now, most places have what's on the right-hand side of this. We have a process for talking to the patient about it and recording it in the electronic medical record. That's called the SOAP note. We have care coordination, pharmacy services, mental health services, if it's enhanced primary care, and community services, if it's advanced primary care. What we need more of are what I call the recovery or the healing services. We need to ask the patient what matters to them. We need to use a tool like the Hope Note or something similar to come up with a personal health plan. And we need to build in and invest significantly more in these kinds of health promotion, salutogenic, recovery-based services, self-care and lifestyle support, social and emotional support, complementary and integrative, and community coordination. And then, of course, we need a team model that can do this, because it's not simply the physician that does it. And we need a value-based system that can actually cover all of these investments. Here's a set of tools that we created several years ago with a group called the Integrative Health Learning Community. It involves a set of questions and questionnaires for having that conversation about whole person, and then a whole set of resources for developing a personalized health plan. We tested this out in a learning collaborative around the country where we asked centers if they would implement it and give us the issues that came up, the challenges that came up to do that. Jamaica Hospital, that I'll talk about in a minute, was one of those. Those were published in 2 publications. You can look at that in the Annals of Family Medicine and also the Journal of the American Board of Family Medicine, where we describe those. But I list here some of the leading whole change requirement needs and the challenges that these systems ran up against. You can read them yourself, but they have to do with leadership. They have to do with the need for payment models that worked with this. We needed a way of tracking, and I'll talk about that in a little minute. We needed to train members on how to do that because I didn't learn this in medical school. We need to incorporate tools that would invest in salutogenic, and then we need to be able to evaluate it, track the risks, the health, and the costs, and lay out sustainability methods. And if it can't work in a diverse population, not simply a privileged population, then it won't work for the nation. Here's some examples of groups that implemented some things in that learning collaborative. As you can see, some of them were piecemeal, but still significant. The Cleveland Clinic Family Medicine Department decided to put the Hope Note tools as a key part of the annual wellness visit for Medicaid every year that the patient came in, and that worked pretty well. That was the Susan Samueli Center already had a robust integrative center, but anybody outside that center didn't know how to do it and didn't know what they were doing, so they used it to train other specialties and other sites in their hospital at University of California, Irvine, on how to do that. But the one that really sucked it up, I think, the most comprehensively is the Jamaica Hospital Medical Center in Queens, where they began to train staff. They redesigned special clinics for delivering this. They incorporated health coaching and group visits, and they built nutrition kitchens and training gardens, and markedly enhanced their disease and chronic disease management program. They embraced whole person care and developed a system for doing that, and I'll show you some data that's starting to come out from that. So the problem that they and many of these systems ran into was that we didn't know how to measure nothing. What do I mean by that? Well, if it doesn't happen, then it's hard to know if it's there, right? If it does happen, then it's easy to measure. And disease process driven by pathogenesis is easy to measure because if you get sick and you walk into the hospital, I can capture that with cost. But if it does not happen, then it's invisible. So we needed to come up with a way of measuring what was not going to happen in those areas. And another member of the founder of Primary Care for All, Scott Carver, who runs Converging Health, happened to have developed a method for that, and Jamaica began to adopt that. That metric tool is not simple. It's called the Whole Person Risk Score, because remember, what we're trying to capture is what does not happen, the flow of water up into the cost issues and the disease illnesses. It is made up of several components, but the sum of it measures absolute risk of disease and costs. It measures the quality of care, the right care at the right time, and it measures the ability of the patient to be engaged in navigating and using the healthcare system, and the ability of the system to assist the person in that. That risk score then was linked to cost to allow us to measure how risk and cost came together. And the term for that is the Whole Person Risk Score. And they divided patients up into these 4 categories: low risk on the left-hand side, high risk on the right-hand side, and then high cost on the top side. And what they found, and this is not unique to Jamaica or any other place, this is exactly the situation throughout our entire health care system. It's only a very small percentage of people that were eating up all the costs. Those who didn't have risk and weren't sick didn't come in. Those who were at high risk that didn't know it would then go up and to become high risk and high cost on a regular basis. And the risk score captured this so that a whole person salutogenic or healing focused approach could capture that going. So here we had a tool, Jamaica had a tool for measuring that. And the goal here then is very simple. It's moving people from the right-hand side, especially the upper right, to the left-hand side. This is where healthcare needs to focus, producing this as the primary goal. We know that there's an 18%, in this case, population that moves to the high risk, high cost yearly. If we could reduce that even by a few percentage, we would save huge amount of suffering and money. Without doing it, the water keeps flowing up there and people keep profiting off of it, increasing cost, workload, and burnout. We know that 70% of this is preventable through education, proper disease management, and behavioral changes. Salutogenesis, moving towards health, needs this kind of focused analytical recovery in that area. Well, what did this look like and how did they do it? And did it actually move people down this list? Yes, it did. Jamaica set up, Jamaica, by the way, is a major safety net hospital. A vast majority of patients are Medicare or Medicaid. They did, however, have a population, 37,000, that were fully capitated, very important. In other words, they were paid a per year case on that. And so this population, they tested this whole person model out and metrics out. They found that 13% of them were in the high risk, high cost, and as expected, took up 76% of the entire population's healthcare costs. 35% fall into the high risk, low cost. These are the people waiting to go up into the upper quadrant and start costing a whole lot of money. From 22 to 23, approximately 25% of the high-risk cost had a whole person care system implemented where they were offered and encouraged to do something called a high-value visit, or an HVV. Then the whole person risk score was adopted to try to capture risk and score. What is a high-value visit? It's basically a way of creating whole person care. It is a 40 to 60-minute visit. The patient is asked what is most important to them in their life and what determines what links to their healthcare risks. It utilizes a whole set of salutogenic or health promotion tools, including some that I mentioned, Hope Toolkit, but many others. It established a personal patient navigator for these folks to help them actually stay focused on the health promotion component. And there's a list in here: lifestyle, healthy eating, physical activity, and stress management services that were offered. It made sure that the drug and treatment costs and compliance were actually being delivered. We know that 50% of individuals don't take what's prescribed, even when they can afford it. And so there was a heavy emphasis on increased access to medical services that produced health education and intensive health education. It attended not just to physical components, but to the behavioral, mental, social, and spiritual aspect. This is really, really important. There's been a lot of emphasis on the social determinants of disease, and certainly poverty and lack of resources is a huge driver of healthcare. But an individual may need other things. And so personalizing that to the individual is what's required. They then, most importantly, selected those who were at high risk or were already at high risk in generating costs within the system. They used a risk score of over 43 and then proactively reached out to these people. So this gave them an idea of where they should focus whole person healthcare to get the biggest bang for the buck. And that's where the whole person care high risk. I won't show you all the data. We don't have time, but I think two of our members who did this are on the phone and actually can be part of the conversation. They saw over about 2 years of implementing these high value visits, those who had high risk significantly reduced their risk. In the blue bars here, those who got usual care, and remember, Jamaica is providing really good primary care in these areas. It didn't change at all or slightly increased. There was, in fact, a reduction of risk of 19% over that 2 years in those that were high risk. This translated significantly into costs. The estimate now is that about 22% decrease in costs on average over 3,000. And if you multiplied out that into the system in 2023, that saved them over almost $13 million. And I'll let Alan tell us whether that's a large amount or a small amount for the Jamaica system. In addition, where did these cost savings come from? It's saved because they prevented approximately 1.3%. Doesn't sound like a lot, does it? But it made a huge difference. 562 people from getting up into that high cost category, which was a 22% drop. The total cost reduction I've already mentioned, almost $13 million. Emergency department use dropped in the high value visits by 22%, and hospital admissions also dropped by 22% in those who got high value visits in those areas. So did it save on suffering? Did it reduce your risk? Did it produce health? Yes, and it saved a significant amount of money. So I would suggest to our leaders, our thought leaders, our policymakers, as they go in and try to answer this question of what type of healthcare do we need, that we need a healthcare, and especially a primary care that focuses on healing, that shifts from pathogenesis only to salutogenesis, that delivers whole person care for each individual based on what they need, not what on average the population needs, and that they measure the reduction in risk, which up to this point has been invisible and therefore not used as part of the payment metrics for those patients. This needs to spread. We've developed at our foundation some educational tools, free CME programs that you can find on our website. It needs to be implemented in practice, in education, and in policy. We also need to begin to communicate this somehow beyond the healthcare system, mostly to our business leaders, and some of our folks are doing that, to show that if we do whole person healthcare, it will in fact increase the well-being of our nation, and that more than anything that they could do will increase its prosperity. We need to get in the ears of the popular public. And there's a lot of books out there about longevity and maintaining your health as Gen Z and Gen X and others begin to age. And here's some examples of books that are out there, and they're focused on salutogenesis. How do I maintain health? The one on the right, Outlive by Peter Attia, has been on the New York bestseller times, I think, for about 4 months now or longer. And we need to somehow communicate how whole person primary care can do that. So I want to thank you very much, and I look forward to comments and corrections from anybody on the call and a robust discussion.
We thank you so much, Dr. Jonas, for your presentation. If you have a question for Dr. Jonas, please post it in the chat and we'll answer them in just a moment and get back to our robust discussion in just a minute. We'd like to ask Dr. Fine to tell us a little bit more about PC4AA and what it is that we are really trying to get done and some of those calls to action that we have. Dr. Fine? Well, let me jump over and just say, oh, here he is.
Okay, thank you. I thought I had lost you. Thank you again, Wayne. You know, the people of primary care for all Americans can actually imagine a world in which everyone in the United States has whole person care in their own community, actually has access not just to what we've done before, but to salutogenesis, in great primary care practices nearby that are open nights and weekends and can see you the same day you're sick, that can help you maintain your health and help you build your relationships, and then have a whole team of people to help with all that right near home. That's a whole different approach to what we have now. That's why we're working together to build this movement. In the next year, we aim to have 25 communities working on this and 10 state work groups working with community organizations and policymakers to make sure that there are enough health professionals for all communities by building new nursing and medical schools and schools for other health professionals, by creating new scholarship programs so no one has to go into debt to go to medical school or nursing school. So all of those people come back and serve their own communities. And at the same time, those state work groups are going to be working to reform Medicaid and health insurance to support all this work. In our last breakout Zoom 2 weeks ago, we had 5 active work group conversations going at once. And now lots of those conversations are continuing offline as people from around the country are beginning to work together to build this movement, a movement that starts with people like each of you here tonight. By joining and learning how communities can provide primary care to everyone, not just any primary care, but whole person primary care. And by bringing one new person or more each week, we will build this movement together. Our work groups still need more people to roll up their sleeves and be part of the work we're doing. We need writers and graphic designers, social media people and fundraisers, community organizers and facilitators. There was a call just today for graphic designers to help with the state playbook, which is being written so that as it's getting written, we make it not only smart and effective, but also beautiful to look at. So please click the volunteer button in the Contact Us section of our website to tell us how you can help. Together, we can make sure that everyone in these United States receives equal health care and gets equal health, regardless of where you live, how much you earn, what community you come from, or what you look like.
So, Patty, if you don't mind, I am looking at
Yeah.
the some of the comments and questions in the chat, and there's a lot of them. Can't get to all of them or answer all of them. Some of them are great. What kind of professional development did you do for the practitioners who did these visits? And I'm going to let Alan answer that in just a minute because they did a huge amount of professional development to do this. They had one question. I will answer one before that, which is, was it randomized? No, it's not randomized, but it's also not self-selected. So it's neither of those things in there. These patients were selected based on risk scores. Okay. And they're trying to get, all of the high risk folks in this, and they think they can do that. And they're opening up clinics to do that. Do they need randomized studies? Of course. I mean, we need randomized studies in these areas. However, this is the kind of practice and program improvement that goes on in healthcare all the time without randomized studies. And most of the evidence that's in the things that they provide, many of them, especially some of the behavior changes, the mental health, the lifestyle, have been tested in randomized studies, or at least in large cohort studies that they're accepted as standard evidence. So those areas, it did require quite a bit of professional development and quite a bit of changes. In fact, there's special clinics that are now being developed to help do this. And I'll let Alan answer that question.
So I wish I could say I did this on my own and had a magic sweet sauce, but it wasn't true. It was with the help of wonderful people like Dr. Jonas and Dr. Scott Connard and his team at Converging Health that, I was fortunate enough to seek out and meet at, national meetings of our specialty and start talking about what we needed to do to change the healthcare system. And we did simple things like we had a mind shift of going from sick care to well care. We went from one of being reactive to proactive, and we became proactive by risk stratifying our patients. So no, we didn't randomize people. We looked out and who were our sickest patients, and it wasn't doing it to save money. It was, what can we do to help these people live better, healthier lives? And we changed from sick care to well care by reaching out to these folks, bringing them into these high value visits, and looking at what mattered to those people and not what's the matter, and utilizing an advanced primary care model like Dr. Jonas showed so well in the slides. And it's been really a 3 or 4 year journey. We got slowed down a little bit during COVID, but a lot of it is about having data, knowing who your sick folks are, and, not waiting to meet them in the ER, but stopping them before they get there. And, we're having great satisfaction of our patients. We're having great satisfaction of our providers. So I know this works, and I'm not sure exactly. I'm not the research scientist here, how you would randomize this, but I think we clearly showed on the data that Dr. Jonas showed that we were able to make a significant impact, not only on these people's lives, wellness, and health, but we ended up saving the hospital system a lot of money. So I think it was a win-win-win-win-win. And a system like this really helps meet the quintuple aim. Queens County is the most culturally diverse and one of the most underserved counties in the United States. And if we could do it there, that with no money, that if people had money, they could really do this anywhere.
Yeah. I think that's great. There's one comment here that said this is precisely what we do in the East Side Health Alliance in Seattle. There are a number of population, especially community-based groups that provide public health and high quality primary care in underserved populations that can do very similar things in these areas. But I'll ask you, why has this not actually taken hold? I sit on 2 policy committees right now, okay? One dialoguing with CMS, and another one just started today by ARC, and they're looking for models of care, right? What are the models of care for whole person health production, community-based population health stuff? So if they were out there, and if they were proven, and if there weren't challenges driving things the other direction, why aren't they spreading? Okay. And so we need more of those. We need to articulate them in some way to make them compelling to everybody.
Well, I don't know who made the comment, but someone made it really well. We don't really have a healthcare system. We have this market-driven mess, and it's all about driving procedures and sick care and sending people to the hospital, who's making the hospital's money and pharma money and everybody else, which is why we need organizations like we have and to do the work we're doing.
Yeah. There is a question about what an individual practitioner can do when they're in a system that, is they're seeing, patients every 15 or 20 minutes. And, you do have there, ultimately, there does need to be a redesign. And I showed you, some of the redesigns and some of the changes that went on at Jamaica, and many other systems have done this. And even if you're in a system that hasn't made the practice improvement change, you can do that. And you can at least begin to have these conversations with patients. And the HOPE tools are designed specifically for that. How do you sit down and actually have the conversation about what matters and about the health promotion and wellness components that are needed in those areas? And many of these networks did that in those areas. So you can get started. Okay, you can begin to do it, no matter what system that you're in those areas.
Well, thank you so much, Dr. Jonas. One of the things that I will add here is that I am a doctor. I'm not actually medically trained at all. I'm a mom and I work in nonprofit, right? And this makes sense to me. One thing that I admire a lot about this group and what Dr. Fine has said is that we are not here to admire the problem, we're here to fix it, right? And so I guess my question for you, Dr. Jonas, is what is your motivation and what success are you seeing through PC4AA as a member of the board, right? What are you seeing that is actually not just looking at this problem and admiring it, but really taking action to make a difference?
Well, I practiced my first 20 plus years, 24 years actually, in the military. And it had a whole person care system. The best clinic I ever had actually had all of the things that they're talking about in primary care for all. And I watched over that 20 years as that got eroded. It actually got eroded, even though it was a capitated system. It sort of picked up the bean counter components and started putting in RVUs. And the new electronic medical record that's just been implemented in the military clinic that I practice in requires that I put in billing codes. Okay. which I never used to do before in those areas. And so, we're losing the process even in those systems. And so when I saw that for people not for profit and knew that what Dr. Fine was doing and had been worked from the top down for so many years to try to make system and policy change, I realized it was not going to happen unless it came from the bottom up. And so that was my motivation for joining.
Thank you so much for sharing that. I know that there's a ton more questions, and part of what's so great about this group of getting together every other week is really that we are starting to have more of these discussions. This is a group of motivated people who is showing up again and again. And in fact, I believe Dr. Fine, do you want to tell us a little bit more about what's happening next for
Well,
PC4AA?
Before I do, it looks like Dr. Connor just raised his hand, and I'd love to hear from him as well. And then I'll jump in a little bit.
Yeah, thank you, Michael. I will be quick. The young person who asked about, what would they do or what do they see we could advise them to do in practice? The answer comes down to become a leader. And what I'm hoping as a fellow board member and co-founder of this organization with Larry Bauer and Alan and I, the three of the 5 or 6 of us that founded this, worked at Jamaica. And the reason that we were successful, the reason we had the things that you saw tonight is because of the leadership of Alan Roth and his vision of what could be done in one of the most difficult environments that you could possibly be in. And it's because of his leadership that people are going to live longer, see their grandkids, grow up, have and graduate from college, high school, and have children. So, the thing is that we need leaders. And that's really the second thing I'd say. Come to these meetings, see these models, read the newsletter, which has just really been amazing. We've got the person who's doing that is a phenom, and he has done an amazing job bringing visions around the world of what's possible. So one, lean into becoming a leader. 2 is keep learning about these models and never give up, never surrender. From one of my favorite movies. And then the third thing is that just whenever you need help or you need support or you need someone who can encourage you to take that next step, you've got a group of peers here that care deeply about developing the next leaders of this movement. And we're all, we've been around a day or two, and we look forward to working with you to help you, grow your vision. So thank you, Alan, for your leadership. Thank you, Wayne, for articulating it so well. And thank you for attending tonight.
Yeah, and let me second that. The great community organizer, Saul Alinsky, used to say, quoting Hannibal, either I'll find a way or I'll make one. One of the interesting things about the last 30 or 40 years is many of the ways we thought we had found were kind of blocked from above. And lots of us have ideas and understanding about how policy works and how we can make this better, and have good models and well thought out models that have been tried. There's a whole mess of data that says, this primary care thing really makes sense. All we got to do is get it to everybody and get it and do it right. The problem is just saying that doesn't get us anyplace. What gets us, I think what we've all come to believe is that this is not going to take a bright idea. This is going to take a movement, and building a movement is a crazy, huge undertaking. No sane person would ever do it. The problem is we've got no other choice. There are no other options. Remember that the folks who have something to sell, who are taking something like $2 trillion or $2.5 trillion a year out of our communities, aren't going away just because we say, pretty please. They're not going away because we say, we have a bright idea. They're going to fight to keep things the way they are. And so the only way we can get them to shrink in what they do is to kind of outsmart them and outrun them, which means building a healthcare system for everybody from the ground up, community by community, working in 25 communities at first, and then going to 100, working in 3 or 4 states at first, and then going to 10 states, and then to 20 states, and then to 50 states. It's not going to happen in a minute. It's going to take way too much work from everybody. The only problem is there's just no reasonable alternative. Healthcare impacts all of us. And it really is beginning to affect how democracy functions, because the guys with something to sell use their money to overturn what most people actually want from themselves, which is a healthcare system, not a market, healthcare system that's for people, not for profit. But when we work together, there's just nothing we can't do. Back to you, Patty.
Thank you so much, Dr. Fine. So for next steps, we will meet again in 2 weeks and break out into work groups again. We encourage everyone to find someone new to get involved in this impactful movement to our next Zoom meeting, which will be on April 30th. Register on our website, primarycareforallamericans.org. And when you're there, click volunteer in the contact us section of the website to tell us how you'd like to be an active part of our movement. And please click donate to support our work. Together with a contribution, every little bit helps. We need and appreciate every single one of you for helping to spread this movement across our nation in order to get the change we need and you deserve. Healthcare for people, not for profit. Primary care for all Americans. We've dropped a link into the chat to complete our survey. Please help us. We want to hear from you. We want you to be involved. If you would like to talk and stay on our call with board members for PC4AA, stay on. We want to grow as a community. Thank you, everyone. We'll see you on April 30th.
Thanks, everyone. Just, I want to mention that there was originally some thought about doing a Zoom for the Rhode Island State Work Group. And my understanding is that's not going to happen.
Right.
I just want to confirm that that's correct, Dr.
Yeah.
Greg Fox.
Yeah. We're
Yes,
not going
and
to.
Lynn, yeah, that's correct. The leaders are toast.
Okay.
So
Lynn-
we're gonna regroup and we're gonna start planning tomorrow for our breakout group. But we'll be communicating with our group over the next couple of weeks and rallying them for the next breakout.
Great. And Lynn Blanchette and
Yep.
Greg Fox have been great leaders of that. Lynn, I actually didn't see you on the Zoom as I saw Dr. Fox, but both of you together have been fantastic.
Yeah, we're super excited for this. We got an amazing group of folks gathering, and we got a lot of ideas. So we're excited about Rhode Island.
And there's a Massachusetts state work group that is started, and a California work group that's coming together. So if you're interested in any of those, please email me or send us a message and we'll get you hooked up with that. Thanks to everybody. We'll see you in 2 weeks.